Hi, my name is Xin Shu, a nursing student in Heartland Health Care Center. I am going to present a patient to you right now. Patient is a 69 years old single Caucasian female. Her former occupation was being a cashier. Patient was discharged from St. Joseph Hospital on August 11, 2014 and admitted to the Heartland Health Care Center for impaired speech and a lower left extremity and upper right extremity paralysis. On July 16, 2014, patient was presented to St. Joseph ER through an ambulance with dyspnea. She was found to have pulmonary edema and be in hypertensive emergency. An echocardiogram was performed and revealed that she had a severe MR due to posterior leaflet prolapse with flare scallop. She then had an XR chest view which projected that a 6 millimeter small right apical pneumothorax persisted. She also had acute hypoxic respiratory failure, which required high-flow nasal cannula dialysis. 2 days after, a CT surgery was consulted. Patient has a history of depression, hypocholesterolemia, multiple allergies, and a history of a car accident when she was 18. Her CVA manifested by vision in that car accident. Now she has almost no vision on the right and about 15 on the left, according to her. The patient has about a year's history of progressive dyspnea on exertion and pedal edema for 1.5 years. Temperature is 37.5 Celsius degree, heart rate 102 beats per minute, respiration 33 breaths per minute. Blood pressure is 144/65. Oxygen saturation is 96%. Past medical history: degenerative joint disease, renal insufficiency, acute and chronic respiratory, acute pneumothorax, respiratory failure, aortic valve disorder, and the possible at risk of falling and impaired skin integrity, congestive heart failure, mitral forming of valve, patent forming of valve, pulmonary edema, dyspnea, depression, hypertension, severe COPD, 2 times of CVA. All immunization is up to date. She is allergic to penicillin, contrastite, aspirin codeine, shellfish, latex, and iodine topic. Past surgical history: post-cardiac surgery, MVA, brain surgery related to CVA. Patient is on numerous medication for hyperlipidemia, depression, and pain. She is also on speech and physical therapy 5 days a week. She wishes to leave the health care center soon and be able to walk on her own. Functional assessment: 40-pack year cigarette use, which she stopped it in 1998. No alcohol or other drug use. She denies any eating difficulty, but her doctor suggests meats need to be cut up into bite-sized pieces and no sugar added to her meals. Psychosocial: she has been diagnosed with depression for more than 15 years and is taking Prozac daily. She has a sister that lives close to Signal, who is her closest family member. Her sister visits her on her weekly basis. Coping strategies include looking at the woods from her window, go to church, and talking to other patients in the healthcare center. Patient is very spiritual and identifies herself as a Protestant. Family history: CAD and aortic aneurysm. No further information was able to be obtained due to her impaired speech. 2 assessed systems: respiratory, review of system. Patient complained tingling on the left foot if it's not supported. Upon examination, patient is alert, pleasant, and with no acute distress. However, her speech is unclear due to her past stroke. Patient declines any history of asthma, cough, or bronchitis. She did have a history of shortness of breath. Patient denies any upper respiratory infection or pain with breathing. Upon examination, a scar is located in the center of her chest, approximately from the 3rd rib to the 5th. Examination: AP transverse diameter ratio 1:2, skin pink, constant with the rest of the body, even regular and coordinated breathing pattern and depth. No signs of distressed breathing. Rate appropriate for age. Trachea, midline enlarged. Expansion is smooth and even. Tactile frematus diminishes as I go lower. Posterior ribs and thoraxes. Structures aligned, symmetric, without masses, crepitus, deformity, or tenderness. Bronchiphony. 9 was muffled. Egophony. E heard, whispered, pectoraloquy, whispered 1, 2, 3. Cardiovascular. Review of system. Patient has a history of heart disease and murmur. She claims that she has a 2 out of 10 pain on her chest that is refractory to her post-cardiac surgery. Patient is currently on a wheelchair assistance and cannot walk or balance on her own. Patient needs assistance to lie flat due to her lost function of her upper right extremity and the lower left extremity. Upon examination, lifts are over aortic area and Erb's point. Normal PMI, aortic, pulmonic, Erb's points, tricuspid, mitral area S1, S2 were osculated both with a diaphragm and a bell. A chronic cough without wheezing was heard over pulmonic area. A 3 out of 6 murmur heard at a patient's mitral area when using bell. 2 pertinent systems. According to the article Life After Stroke, published on March 26, 2014 in National Heart, Lung, and Blood Institute, patients who recover from a stroke facing challenges in urination. Weakness in a person's arm or leg make it difficult for them to go to the toilet or to use a urine bottle because they may have poor eyesight, may experience difficulty in adjusting clothing and communication. Therefore, they might refuse to eat or drink to avoid needing to use the toilet. Given my patient's reduced functional ability and a history with stroke, it is important to assess her abdominal system every 4 hours. Another pertinent system that would be important to assess is her muscular system. According to an article published in University of Pennsylvania Medicine on May 28, 2014, people with stroke would experience loss of balance and coordination, muscle weakness in extremities, numbness or tingling on one side of the bodies. It would be my patient's best benefit if a muscular assessment is conducted so that her strength will be well rated and the necessary assistance will be provided. Thank you.